AACE guidelines for management of dyslipidemia and prevention of cardiovascular disease.
Thank you, Bart. Just came off the workshop, so we're ready to go. I've been allotted 20 minutes to do quite a lot, so we're going to speak a little bit fast and also not cover many of these slides in detail, but just point out some highlights. And, hopefully, we won't run over too many minutes with it all. So this is me. I don't know. I just heard something from you. You dare run over? I was privileged to be the chair of the writing committee for the AACE guidelines for the management of dyslipidemia and prevention of cardiovascular disease. It's a product of both the American Association of Clinical Endocrinologists and the American College of Endocrinology. We had a really good committee, and I'll show that to you in a moment. But this all began because even in 2004, it was apparent that the lower was better. This line goes straight down. And these are earlier studies. There are studies that came out after this that continued to show that. And secondary prevention trials almost predicted that the event rate would be 0. Maybe that's a little optimistic. The LDL was 30, but clearly there's a straight line down. Every trial that achieved the lower LDL did better than the other trials, and the patients within the trials who achieved lowest LDLs did the best as well. And just to change the tone a little bit, just recently at the European Society of Cardiology's session about a year ago, Dr. Jean Bromwell was asked to comment on the European Society's guidelines where they had targeted an LDL of less than 70 for very high-risk patients, just having repeated what had been stated for many years before. And Dr. Bromwell, who many of you know as a renowned cardiologist, was very frank and said, I don't think the European Society of Cardiology went low enough. The LDL goal should be less than 50. Anything above 50 is toxic. So we have a committee who was armed with all the data that pointed strongly to the lower is better. Yehuda co-chaired it with me, and a very prestigious group of individuals. I was happy to work with them all and get the job done. We had several reviewers. Our practice guideline was an evidence-based education resource where evidence existed. It was a practical tool for endocrinologists and other healthcare professionals and regulatory agencies to reduce the risk and consequences of dyslipidemia. There are 87 recommendations. 45 are grade A, 18 are grade B, 15C, 9 are D. There was, after the executive summary of about 18 or 20 pages, there's a 60-page evidence base with 695 citations, and you can see the evidence levels are rated right there. Very extensive source document or evidence base follows the executive summary on the AACE website that you may want to look at because it's a very good source. So what do we try to do in the AACE lipid guidelines? By the way, this wasn't our first. This was an update from the 2012 guidelines, but we did pronounce some very, for lack of a better term, groundbreaking suggestions. So we asked these questions: what are the risk factors? What are for ASCVD? What risk categories and how is risk assessed? And I don't want to go through all this. We added a section which is seemingly lacking in a lot of these guidelines about type 1 diabetes, which we were asked to do, and we have some nice information there. Who should be screened, secondary causes, etc. What are the goals? What are the treatments? We have a nice section on special considerations for women and special considerations for children and adolescents, which I won't have time to show you, but you can read there. I want you to be aware of it. And a nice section on cost effectiveness as well. So this is basically the questions we were asked for the 87 recommendations. We list the major risk factors. No surprises here. Note that polycystic ovary syndrome is commented on as an additional risk factor. We have a section on that as well. There's some emphasis on HSCRP and even LPPLA2 to some extent as well in the document. But the classic risk factors are listed on the left, including stage 3 or 4 chronic kidney disease, which has emerged as a real major risk factor. So these are basically the risk factors we were dealing with, and we included, not in every instance here, but in most of these notations, some discussion in the text about it in the evidence base. So the question we asked first is, how is risk assessed? And there are several risk engines that can be used, and we all know about those. The 10-year risk of coronary events should be assessed by whichever risk engine you like. I will tell you that the group at AACE, including myself and others, feel strongly that the last bullet, the MESA 10-year ASCVD risk for coronary artery calcification calculator, is probably your best tool today. And the coronary artery calcium scoring is extremely useful. It's incorporated in this risk calculator and has made a difference, at least in my hands and others too, as to how to help stratify risk in patients who the risk assessment is not clear. But you have these other risk engines or scoring tools available as well. And we're not directing everyone to a particular one, but do recommend the MESA score as the probably the most accurate. And here's a little bit of information about that. It correlates well with subclinical CVD. It's an independent risk factor for CVD, and uses traditional risk factors and coronary artery calcium score to predict 10-year risk. And the incorporation of CAC into this risk score has improved risk prediction very substantially. You can see in the MESA scoring system that coronary heart event rates in the MESA study the events increase directly with the coronary artery calcium score, and it's based on risk factor burden, both for what are called hard events and soft events, or total events. When your coronary artery calcium score is greater than 300 in that back row, those events are usually increased in association with how many risk factors you have. So it augments and amplifies your assessment of risk based on risk factors, but it greatly amplifies it and hones it down to more precise measurements. The incidence of coronary heart disease and compared to carotid intermedial thickness over several years is shown here, and you can see that coronary artery calcium scores much better than intermedial thickness and is definitely predictive of cumulative coronary heart disease incidence. So we are big fans of the MESA scoring system and the use of coronary artery calcium system scoring, but again, you have other risk engines available. So we are all familiar with low risk, moderate risk, high risk, and very high risk, and that's where it ended until these guidelines were published. I'll show you the LDL goals in a moment. This is where it ended. What we did was we took it a step further, and largely based on the IMPROVE-IT trial and the achievement of an LDL of 53 in the IMPROVE-IT trial with added benefit using ezetimibe on top of simvastatin, clinically significant, statistically significant added benefit. We chose a number less than 55, less than 55 as a goal, 53 being what IMPROVE-IT achieved. So we established an extreme risk category that consists of patients with progressive atherosclerotic cerebral vascular disease, including unstable angina, that continues to persist after achieving an LDL less than 70. Somebody who has coronary disease or angina or ongoing events, and whose LDL is 62 or 66, they are now at extreme risk. We need to continue to drive the LDL down to less than 55. Patients with established clinical ASCVD with diabetes or stage 3 or 4 chronic kidney disease or heterozygous familial hypercholesterolemia. When a patient has diabetes and heart disease, they're extreme risk, less than 55. Or peripheral vascular disease, we were just here in the last workshop, or stroke. Or a patient has stage 3 or 4 chronic kidney disease and clinical cardiovascular disease, ASCVD, or heterozygous familial hypercholesterolemia and clinical ASCVD. They are now at extreme risk. And those with a history of premature ASCVD, less than 55 for males and less than 65 for females. Patients sitting in front of you, you're seeing it at age 54, got a heart attack at age 42, right there and then. They're in the extreme risk category, less than 55. And that may be too conservative, 55. That's where we're starting. So IMPROVE-IT was the catalyst, but the data had been have been emerging for some time. So here it is again, the extreme risk category, listing the criteria on top and the treatment goals. Less than 55 LDL, non-HDL less than 80, ApoB less than 70. How do we arrive at those? Well, the less than 55, as I mentioned, is the LDL achieved an improvement with added benefit. Non-HDL of less than 80, usually that's 30 higher than LDL, but this time it's 25 because improvement. I had a cutoff at 25 and not 30. And ApoB of 70 was partially extrapolated from other trials, but also that's what improvement had determined was the important cutoff at ApoB of less than 70. Very high risk. It didn't change much in this iteration, although heterozygous familial hypercholesterolemia without clinical cardiovascular disease is certainly in the very high risk category. And there's the 70 and the 100 and the less than 80 that you're all very familiar with. And these are patients whose 10-year risk is greater than 20% using some calculator or risk engine, while the extreme risk automatically go into that category, don't need to be calculated. And the diabetic patients, therefore, are either at high risk, very high risk, or extreme risk, based on whether they have any risk factors besides diabetes, 2 risk factors, 1 or more risk factors, or clinical cardiovascular disease. So in terms of diabetes, very important, based on epidemiologic studies, individuals with type 2 should be considered as high, very high, or extreme, as I've just gone over. But type 1, and we don't have time to go into this, we combed the literature on this, at least I did, and we came up with the best available criteria for when to be aggressive in treating type 1s, because there isn't an awful lot of stuff on this, at least in the recent literature. But if you've had type 1 diabetes more than 15 years, your risk is greatly increased, especially if you have 2 major risk factors. For example, albuminuria, stage 3 or 4 chronic kidney disease, and if the initiation of intensive control was more than 5 years after the diagnosis. Just look at the DCCT on that. Poorly controlled hemoglobin A1C, that could be anywhere in the literature from 9.5 to 10.6. Or some studies have even shown that a C-reactive protein of greater than 3 in a type 1 is an indication that those patients have a risk equivalent to type 2 diabetes and should be treated. So type 1s of 5 or 10 years that don't have any of these, albuminuria, chronic kidney disease, and we're been well controlled from the beginning, I don't think we need to get too aggressive with their lipids, but there are criteria for type 1 that make sense. So type 1, after all, is associated with increased ASCVD. They should be screened annually, and they should be treated aggressively when indicated, according to risk level recommendations. Chronic kidney disease, there's a couple of studies. I won't spend a lot of time, and I know it's a run out of time here. The albuminuria deteriorates, albuminuria and GFRs relate to all-cause mortality. The more albuminuria and the lower your GFR, the greater your all-cause and CV mortality. That's why chronic kidney disease is listed as extreme risk, and with cardiovascular disease. And this shows that your event rate is considerably higher when you have proteinuria than when you don't, depending on whether you look at all-cause death, CV death, MI, or stroke. Proteinuria is not a good thing. So one of the things that emerged in our guidelines is the importance of both proteinuria and chronic kidney disease as real risk factors. And the data is there to show that. We have a section on familial hypercholesterolemia. This has achieved new importance because of the PCSK9s, which offer an opportunity to treat these better than we have before. There are 3 ways to diagnose it. We cannot go into that. Most common is the Simon-Broom. The one that some of the insurance companies require is Dutch lipid because it's harder to achieve those criteria, so they want to make it hard, partly for being cynical. But you start thinking about familial hypercholesterolemia when a patient has a premature ASCVD, a fasting LDL untreated or greater than 190, the presence of tendon xanthomas or corneal arcus in individuals less than 40. Tendon xanthomas, don't wait for ping pong balls in the Achilles tendons. Rub your finger along the Achilles tendon. If you feel a pebble, that's probably a tendon xanthoma that may qualify for the use of a PCSK9. Family history, etc. Genetic testing is available, but it's expensive and it's not covered. One point I want to make on this slide is the prevalence of heterozygous FH is not what we thought it was. It's 1 in 200. Who would have thought of that? 1 in 200 to 1 in 250. Before this data became known in the last couple of years, I would have thought it was 1 in 1,000 maybe. Or we all have these patients. We're missing them. They're in front of us every day. Real high LDLs and family histories of heart disease is a starting point. Homozygous is quite rare, 1 in 250,000. But heterozygous is, use an expression, a dime a dozen, and they're in our practices. They do qualify for aggressive LDL lowering if below 55 if they have clinical cardiovascular disease, less than 70 if they don't. So who should be screened? Patients should be screened when there's a family history of ASCVD, and adults with diabetes should be screened, young adults should be screened. We have all these recommendations. Young healthy adults every 5 years as part of a global risk assessment, annually in patients with diabetes, and more aggressively in patients with a history of familial hypercholesterolemia. We continue with middle-aged, older, and children and adolescents. As I mentioned, we have a special section on children and adolescents and women, but I don't have time to show that to you. So there are recommendations about how often to screen. As children after age 3 in some cases should be screened, especially with a family history of premature coronary disease and FH. Fasting lipid profiles are desirable but not absolutely required. There have been some reports that non-fasting lipid specimens actually, the LDL varies by about 5%. If it's impractical, a non-fasting specimen is useful. Plus, I always like to see what the non-fasting post-meal triglycerides are anyway, because they tend sometimes to surprise us to be quite high. But fasting is the most precise measurement. I would avoid a non-fasting specimen if a patient has known hypertriglyceridemia that you've already diagnosed. You're not looking for it, because those LDLs will not be reliable, and you're going to need to do a direct LDL. You need to do fasting. So the LDL, there's a free wall equation. There's a new equation that's out there that's being used. It's a little more precise. I'm shifting my lab over to a Jackson-Hopkins equation. And then there's direct LDL measurements, which should be used in any situation where the triglycerides are greater than 250. And HDL should be measured. Non-HDL is calculated. Triglycerides should be measured. ApoB is a very useful test to assess the success of LDL lowering therapy. When you think you're at your LDL goal, measure ApoB and make sure you're at your ApoB goal as well, because it's much harder to lower ApoB than it is LDL, and you may be surprised. I don't recommend ApoBs across the board, but when you're approaching target, I think it's a reasonable thing to do. So let's focus a little bit on LDL. The cholesterol treatment trial list from 2010 also fed fuel to the committee's decision to establish an extreme risk category. For each 39 milligram per deciliter reduction in LDL, individuals with a baseline LDL of less than 77 had a 29% further reduction in major vascular events. And if their baseline LDL was less than 70, they had a 37% further reduction in major vascular events for each 39 milligram percent reduction in LDL. Quite striking. This is a huge analysis of 170,000 patients. And the Burkhardt study, which I like, shows that when you achieve LDLs of less than 50, you continue to reduce the hazard ratio for major events. The IMPROVE trial we discussed, the ezetimibe simvastatin on the left had a statistically significant benefit compared to just simvastatin. The mean LDL was 53 in that group and 69, less than 70 in the simvastatin group. So going from less than 70, the established goal, to 53 made a difference. And as was pointed out in the last workshop by Dr. Rosenblatt, the diabetes subgroup and the IMPROVE practically drove the whole thing. You can see that how far over to the left, the diabetes subgroup, they really benefited from this lowering of LDL to 53 with the addition of ezetimibe. Glegov, a very nice study, an IVA study showing that there's plaque regression as you go down. What the point I'd like to make about this, I don't know where there's a pointer here, but yes. There's no break point here. It's continuous. There's no threshold. The lower you go, the more plaque regression there is. There's no point below which there's not further plaque regression. I think that's very important. 4A lowered LDL to the floor, 30. On average, you will know about their primary and secondary endpoints. What you you may not realize is that for the singular endpoints of 26 months, very tight lipid control reduced the risk of MI by 27%, stroke by 21%, and coronary revascularization by 22%. And yesterday, the manufacturer got FDA approval for these indications right on the bottom. Stroke, MI, and revascularization. So that's, you gotta go? Good stuff. Okay. So I want to just get to the diabetics did just as well. One comment about statins and fibrates, and then we're done. Because we have a recommendation that additional use of fibrates will improve the reduce cardiovascular events. That's always been controversial. Lowering of triglycerides. I just wanted to point out that in every study that's looked at this, the Helsinki heart analysis, the field study, the mesofibrate study, and the Accord lipid study, which, you know, we're racing through this now, the subgroup in those studies that benefited by being on a fibrate all had triglycerides greater than 200. And in some cases, the HDL needed to be below 35 or 40 to get a benefit as well. But in all 5 studies, they're secondary endpoints, so they don't have the power of primary endpoints, but all 5 say the same thing. So we believe when residual triglycerides remain over 200, there is a benefit to using fibrates. And here's the final slide that once again reiterates our groups and our risk factors and our treatment goals. I urge you to download this from the AACE website, and all the slides I presented are in the syllabus. So thanks for your attention.